to the cloud. Um, she is an expert in adolescent and young adult development, emerging psychotic disorders, and serious mental illness. She has published over 40 peer-reviewed papers and several book chapters on psychosis prediction, detection, and diagnosis and treatment. Her current research focuses on improving communication between parents and youth and increasing access to high-quality mental health treatment for young people in distress. Dr. Kline authored The School of Hard Talks, How to Have Real Conversations with Your Almost Grown Kids in 2023, as well as the School of Hard Talks Online, which is an online course for parents who are hoping to learn to improve their communication with their teens. And as a parent and a clinician that has used these resources, I highly recommend them. It's also my great pleasure to introduce Jenny Lancet, who is a peer support specialist with the RAP program at Boston Medical Center. She provides one-on-one support by assisting others in their own journeys of recovery through sharing her own experiences and promoting hope that recovery is possible. In her spare time, she enjoys photographing the city. Welcome, Emily and Jenny.
Okay, thank you so much for having us. And we're excited to share what we do with folks today. So I'm going to ask for a little bit of audience participation at times. And also feel free to pop questions into the chat. And if I don't catch them, I know Dr. Friedman-Yukubin is keeping an eye on them for the end. So we're here today to talk about sorry, how do I go back? There we go. Engaging with psychosis, especially when people might not have great insight. You know, many of our patients don't show up in our clinic saying, I'm experiencing psychosis. Can you please help me? Right? It's just not the nature of the problem. So how do you help people who, when you don't necessarily align on what might be going on? So for those who've never heard the term, I want to just define what insight means. So in general, I think of insight as the ability to accurately observe your own mood or behavior over time. Another word would be like self-awareness, right? Do I know how I'm feeling right now? And do I have a sense of how that might be different than I was feeling before? And in psychosis, this can take a few different forms, a lack of insight. So it could be that somebody lacks any awareness that their symptoms are occurring. So an example of this that I see is sometimes I'll catch somebody out of the corner of my eye in the waiting area of our program, and they might be talking to someone who I can't see. And then if I ask them 10 minutes later, have you ever heard a voice? They'll say no. Right. And it's not that they're lying to me. They don't have that conscious awareness that that experience is happening in a way that they can tell me about. So that can be one way that low insight can present. Another might be that they know what's happening, but they have an attribution that's different than what I might think the cause of that experience is. So they might say, well, the reason I'm hearing a voice is because there's a ghost in my head that's talking to me, not because I have schizophrenia or I have psychosis or I didn't take my medication today. And a third way that low insight or poor insight might present is just that ability to connect fluctuations in symptoms. So some days I do have more voices, some days I don't. With other stuff that's going on in my life. So I might, if I have really good insight, I might say something like, well, I'm probably having this experience because I haven't taken my medications in a week. Or I didn't get much sleep last night. And again, this can be true in psychosis as not in psychosis, right? So I might have this same conversation with like a preschooler or with myself, right? Where I'm having a really grumpy day and I might have insight, oh, it's because I didn't sleep well last night, or I might not. I might really think that something external is irritating me more than usual. But insight isn't a completely like black or white thing. And that's what Jenny and I really want to talk to you about today. So I think the nature of this is really well illustrated by this very short video that I want to share with you all. And I'm nervous I didn't do the sound correctly, so I'm just going to reshare my screen to make sure that you're all going to be able to hear this nice video. Okay. Here we go.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's gonna stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever gonna stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like, there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Come on, if you would just...
Don't!
Try to see things my way. Do I have to keep?
All right. And credit, as always, to Jason Headley, who is well aware that therapists love this video and encourages people to use it. He's the actor and director and creator here. Okay. So I'm curious if people, for those who have access to the chat, I'm curious what you think. Like, does she have insight? Yes or no, and why did you answer the way that you answered? What do you think? Okay, so we have one vote for yes. Another, she recognizes there is something wrong, right? Somewhat. The symptoms are recognized, but not the source. I think that's very well put, right? She knows something's wrong, but she doesn't know what's causing it. A misattribution, right? She's not describing it in the same way that somebody else would describe it. And maybe we call that, yeah, somebody's saying no, that's a no. If you don't know what's causing it, we're going to say that's not insight. I just really like this video because I think it reminds me of many encounters that I have with people who are really in it with psychosis, and they know that they're having a problem, but we might not be able to agree on what's causing that problem. And sometimes naming what I think is the cause is like actively unhelpful. So let's talk about, what else to say. So in this situation, that you might encounter in clinic or in a clinical setting, even if you're not a clinician, you may see people who lack insight. And I just want to complicate that in some ways that came to my mind of people that I've seen. So one thing is that the experience that the person is having, even if it is caused by their mental illness, is real, right? Like they are really hearing voices. That is a real thing. They are hearing it in the part of their brain that processes auditory stimuli. So they are hearing it. And it's not a lack of insight to say, I really am hearing this. Even though people may be perfectly aware that that's a product of their own mind, or that that's something that happens as a result of their psychiatric diagnosis. So I would say that not quite agreeing on the terminology is somewhat different from totally lacking insight, right? If we can talk about the problem, but we don't agree on the terms, that may just be sort of a language preference difference. And I'm okay with that. I don't really feel any urgent need to resolve it. And the other thing is that for many people with psychotic disorders like schizophrenia or schizoaffective disorder, or even sometimes with bipolar disorder, these things will come up, right? Like these are not one-time illnesses. They do tend to have a more chronic, relapsing, remitting, lifelong course. So it's not that surprising that these experiences are happening. The first time they happen can be very surprising, but over the course of a lifespan, yeah, like these things will reoccur many times. And so acknowledging, oh yeah, I'm hearing voices again, or I'm getting that feeling that my food is poisoned. Acknowledging those experiences is actually sort of a sign of good insight rather than poor insight, which can be a little confusing. The other thing is that insight comes and goes, and it comes and goes as a result of different episodes of the illness, maybe getting better, getting worse, but it can also come and go within the course of a single hour or conversation. And again, I want to take this out of the realm of psychosis for a minute, because I think we've all experienced this. If we stop talking about insight, which sounds very clinical, and just talk about self-awareness, of course, we all know that it's true that how we talk to people about their experiences can increase or decrease their self-awareness. When we are feeling criticized, blamed, I think all have a tendency to get defensive and to say, no, I didn't do that, I didn't say that, rather than when we're feeling safe and we can explore things more openly. And I might say, oh my God, why did I say that? Instead of, I didn't say that. Right. And that's just a result of sort of who I'm talking with, in what setting, and how they're approaching me about what I did or didn't do. And that is true, I think, when people are in psychosis as well as when they're not in psychosis. So if we help people to create that kind of sense of psychological safety, to talk about their experiences and explore where those might be coming from, it will often be much more productive than sort of being, I don't know, more accusatory or, making people feel ashamed or blamed for those experiences. So how do you do that? Well, I find a few of these strategies I'm going to review with you today can be really useful. These are not really treatments for the psychosis itself. None of these things is going to cure schizophrenia or an episode of psychosis, but these are ways of talking to people about the problems that they're having that make it more likely that we can get to that next step of, so then what? What is the intervention? If we can't even talk about the problem without a lot of conflict or shame, we're never going to get to the solutions. So these are ways of just kind of trying to have that conversation, create that sense of safety, that we can have a productive conversation about, what this person might want to try, whether that's a medication treatment or spending time in an inpatient unit or engaging with an outpatient therapist. What is the treatment that we're going to recommend? This is sort of how you connect the pieces of the puzzle to get there. The strategies that I'm going to review are mostly borrowed from a practice called motivational interviewing, which is an evidence-based technique that was developed in the context of substance use disorder treatment. So that's another area where, again, there's a lot of sort of black and white thinking about acceptance, denial, having insight, not having insight. And it's ultimately sometimes not all that helpful to go back and forth on whether somebody's in denial or accepts a need for intervention. What I like about motivational interviewing is that it's a really concrete set of tools that are very replicable. So you can learn these and apply them in lots of different conversations, even though it's not an exact script. So the first tool is called reflections, and reflection basically means that I'm just going to say whatever the other person said back without really agreeing or disagreeing or showing any judgment whatsoever. So if somebody says to me something that really doesn't make a lot of sense, and I suspect it's sort of a manifestation of their psychotic thinking, I might just respond with a reflection. So I might say something like, you feel like people are out to get you, or you're not sure what to do. or it feels like no one believes you. Or I might just reflect the emotion that they're showing me and say something like, you seem really frustrated, or you're under tremendous stress. And notice that my voice kind of goes down as I say these things. These are not questions, they're just reflections. And I can offer these as a way to show that I'm listening, and whatever your experience is, I'm interested in it, I accept it, and I want to hear more. The next tool I want to give you is just find out more by asking questions. And these are questions that are not meant to kind of prove or disprove the experience, but just really to learn about it more. So these are all good questions to ask somebody when they disclose an experience of psychosis. So you could say, how long has this been happening? Has anything like this ever happened to you before? What does your family think about this problem? That can be a good way to get at sort of the cultural wrinkles too, of sort of, is this a shared belief that I'm just one that I'm not familiar with? Or is it something that even your family is like, no, that doesn't sound right. You can ask them, why do you think this is happening? And then I really like to find out sort of the todayness of it, right? So sometimes people have these experiences very chronically, or for many months or even years, without telling anyone or looking for help. So if someone came to talk to me today, I'm curious why they came today. What was it about today that made it different? Because that can often be quite informative in terms of figuring out what would be helpful. Once I have, used some reflections and maybe gone back and forth between reflecting and asking questions to learn more about the experience, I want to start thinking about solutions. So, how can I help you today? Or even if I can't help you, what might be able to help you that I might be able to sort of pass you along to the next person who can help? So I like to start that part of the conversation by asking the person, like, well, what do you think could help? Or what did you come here today hoping for, right? What would be helpful? And these are all real responses I've gotten from people who are in psychosis about what they think would be helpful to them. Some people will say, well, I just need to get back on my medications. Other people would say, well, I really need the FBI to leave me alone. They might say, I just need a good night of sleep. Might say, I need a job. Or some other non-mental health related stressor, like I need my green card, I need a job, I need a new apartment, right? Or they might say, I have no idea. So these are all, things I might or might not be able to help you with, but I'm curious to know what you think would be helpful. Now, I really like to ask other people their perspective. As you can tell, I think that's very important. But I went to school for a long time, and I studied psychology, and I've treated a lot of patients, right? So I have some ideas too about things that will be helpful, and I don't want to be shy about sharing those, right? People didn't come to see me just to hear themselves talk. Hopefully they're also interested in what I think. And I don't want to withhold that in the name of being sort of patient-centered. I think we should both share our perspectives. I like to get permission to offer my advice as just a way of sort of respectfully pivoting to, hey, I'm gonna put on my sort of expert hat here now. Is that okay with you? And it might sound like, one of these statements, just, can I share my perspective? Or I've seen a lot of patients actually describe something similar. Do you want to hear what helped them? And then I want to give my advice. So I usually, by this point in the conversation, will have some idea of what might help. Maybe it's something like, I agree, you should go back on your medication. Or I really want you to talk to one of our prescribers. I think they might really be able to help you feel better. Or I might say something like, I'm worried about your safety. I want you to go to the emergency room. Or it might be something a little bit lower stakes, like, well, it sounds like in the past, just taking a few days off and taking a PRN or playing some video games has really helped you. Do you want to do that? That's my advice. And then if it's appropriate, I think it's really nice to hand the control back over, right? Because my advice is simply that, it's my advice. In 99 out of 100 cases, it only matters to the extent that they want to follow it. So I will often then gauge, like, okay, so what do you think you'll do? You know, and it's a way of sort of, you know, understanding that I'm not in control, you're in control. I've offered my advice. Do you think you're going to follow it? And sometimes the answer is yes, and sometimes the answer is no, and sometimes the answer is like, actually, I feel a lot better now that I've talked to you. And that doesn't mean that I didn't do anything. It means that actually I helped them, right? Like I was able to provide some pressure valve for this experience that they're going through. And I've given my advice, but right now, just talking about it actually brought tremendous relief, and maybe they'll come back when they're ready for more. Okay, so that's sort of like some strategies that work, but we also want to talk a little bit about what not to do. So I will hand it off to Jenny, and Jenny, just let me know when to advance the slides.
Okay, thank you. So one strategy that definitely is not often, does not often work, is an immediate and exclusive focus on meds. So oftentimes, I think the first questions in these first encounters are, you know, what medication are you taking? Have you tried X, Y, and Z? You know, you really need to be on meds. How about some ECT or TMS? You know, kind of coming in and immediately thinking a second or a third medication might be helpful. And I think one of the issues here is that there's a lot of assumptions that are being made. You know, we're assuming that the symptoms are distressing to the person coming in and that they want to eliminate what's going on. And I think for some folks, it's a comforting experience. It might, like Emily kind of talked about earlier, there might be a cultural component to it. So really just leaving space to kind of explore further is a good starting point. Second slide. I think a second is the black and white attitude towards compliance. So oftentimes, you know, you hear someone who doesn't want to take medications is that they don't want treatment and to please come back when you're more motivated to engage. Or before being offered other services, they need to be taking medications. And I really think, you know, kind of using a lens of curiosity and kind of trying to align with what brought that person in today is going to be most helpful, kind of trying to get to the root of the motivation. Like why did this person, like Emily said earlier, why did they come in today? And how can we kind of align with that? Next slide. Also there's like a narrow focus on insight. So immediately asking, you know, the person coming in, do you have psychosis as a prereq for services? And if someone wants to talk about their experiences, they immediately want to go to reality testing. And I think oftentimes, like, it's important to talk about your experiences and what that means to, you know, to the person experiencing it. And they might not be in the frame of mind that I immediately want a reality test. I kind of want to explore what this means to me and kind of what's beyond that. Next. And the last is, you know, using when providers are using stigmatizing judgmental language. So, you know, being flat out mean or defensive when the person coming through the door has questions and using hostility. I think, you know, inherently when they're coming in, there is a little bit of a power differential. You know, you might be a psychiatrist, a nurse practitioner, a therapist, and just really reminder, you know, that the provider may be the expert in their area, but we're also the expert in our own lives. And I think it's been, in my experience, much more effective when it's viewed more as a collaborative partnership and you kind of, you know, use that curious lens and kind of see, you know, where you can kind of align.
All right. So are we ready for our role play? Okay. So I'm going to use these slides to kind of keep me on track, but you're going to see us kind of act out what this might look like, both in terms of the what not to do's and then the maybe more motivational interviewing based. And we're going to use our slides to really guide both conversations so that, you know, we stay on track and we can bring it to light. So I am going to be I'm going to be like a psychiatrist or a nurse practitioner. And Jenny is going to be a patient I've never seen before. Okay. So, all right, come on in. What brings you in today?
The judge said I had to come in it's part of my court probation. I gotta come in and meet with you.
Well, your judge probably said you needed to get some treatment, so you need to get you some medication.
I'm not gonna take medication.
Okay, but the paperwork that the court sent over said that you have schizophrenia, and so I really don't know what we're doing here if you don't want to take medication.
I don't have schizophrenia. I don't talk to myself. I'm not crazy. And I'm not taking meds. So I'm just here because they said I had to be.
So you don't want treatment?
If that's meds, no.
Yeah, it sounds like you're not very motivated. Maybe you're just here to get the slip that says that you came to treatment, but I'm not going to sign that for you if you're not actually going to get some treatment.
Well, then that's it.
Okay. Well, do you like understand your diagnosis? So you have schizophrenia?
I don't have schizophrenia, no.
So I think maybe you don't know what it means. It means that you like have hallucinations and delusions, and it means you're like disconnected from reality. And my job is as the doctor to give you some medication for that, because that really is the treatment. And it sounds like you're in a lot of trouble.
Yeah, I got in trouble with, the system, and now I'm having issues, but everything is real. Everything that's happening is real. It's not because I'm crazy,
Hmm. Okay. Well, do you have any questions for me?
Nope. Just if you could sign the paper.
I don't think that's going to happen. Okay. All right. So that was, I tried to, hit most of the points in Jenny's slides here of sort of being a little bit mean, defensive, a little bit confrontational with my clinical language, like, do you even agree with this? And really seeing her as an unmotivated person because she isn't like 100% on board with the medications that I would feel comfortable prescribing for her condition. So I'm gonna back up and we'll try again and we'll follow these slides. All right, ready? Okay. All right, so what brings you in today?
I got in trouble and the judge told me I had to come in and meet with you and just talk.
Okay, so you were sent here by a judge.
Yeah.
Okay. Do you know why the judge wanted you to come here?
Well, I got in a fight with someone on the street. And they got arrested me and then ended up, in the system, and now I'm back and they told me I needed to meet with you as part of my conditions.
You're fighting.
Yeah. Just a stranger on the street. And I guess it also happened with my sister.
Do you have a sense of why, what's triggering you to get into these kind of confrontations?
Well, someone's telling me to, I just hear this, that I need to fight this person. And I also heard it, with my sister. That was a big argument too.
So you're hearing a voice telling you to fight people.
Yeah, I'm hearing a person telling me.
Okay. How long has that been happening?
It's probably been about a few months. I want to say.
Okay. And like when you're with your sister, does she hear it too?
She says she doesn't. She says that it's me and it's all in my head and she can't figure out what I'm hearing and why I'm being told to do this. So she says no.
That's very confusing.
Yeah.
Why do you think, like, where do you think that voice is coming from?
I don't know. It's kind of confusing because sometimes I feel like it's really real and it's happening and I can sense it. And then other times it doesn't make as much sense. I might be home and no one's there and it just doesn't really make sense to me.
And what is there anything other than the court order that made you decide to come here today?
You know, something that's been happening is I'm having a hard time with my sleep, honestly. I've been sleeping on the couch because my room kind of just feels really unsafe, and I'm kind of scared. It's like closer to the world. So the middle of my apartment feels a lot safer. And so just being on the couch, but it's starting to get uncomfortable kind of being there.
So this voice is troubling and confusing, and you also have not been sleeping well because your room doesn't feel safe.
Right.
Okay. Okay. So, do you have any, like, has anything helped with these things in the past, or do you have any ideas of what might be helpful?
Honestly, just keeping to myself has been comforting. So I kind of just stick to myself. I try not to see my sister, or, people as much, but I have family stuff coming up, so I know I'm gonna have to see them.
Okay. Um, it does sound confusing, and at the same time, I feel like I've seen kind of similar people come in with similar kinds of problems before. Can I share with you some of the things that have helped them?
Yeah, sure.
Yeah. So, well, the main thing actually is medication, because when people are both feeling unsafe and feeling like there's something really unsafe around them, that can be real, but it can also be like a symptom of psychosis. And when that's combined with hearing voices, that's really that tips my thinking towards psychosis. And psychosis, actually, you can treat that with medication. So my advice to you is that you should take some medication, and I can walk you through the options. What do you think?
I don't know. I don't know if I want to take medications.
Okay. Is there anything else that you think could be helpful?
I mean, there's people I can just talk to, right? And kind of figure out some of this family stress and
Oh, yeah. So, medication is something I can offer you today. But if you think it would be helpful to talk to one of our therapists, I can put in a referral. It might take a few weeks.
yeah, that sounds good.
Okay.
I'm okay with that.
I'll do that then, and maybe we can follow up, and you can let me know if you've had, if you have any questions about the medications, um, even if you decide you don't want to do it today.
That sounds good.
Okay. All right. So those were our two role plays, and I tried to really stick with the script, both to make it easy on myself, and also because I want to show you this like isn't rocket science, like I'm not going with my deepest clinical intuitions here. Like, this is fairly scriptable. So I'm curious, like, what people noticed about the two conversations, and what was different. We have a big group, so people could put it in the chat. I'm sure everybody would love to see your comments. So I really avoided confrontation. That is true. I offered some different choices the second time. Yeah, I tried to be non-judgmental, even when I said, hey, this sounds like psychosis. I tried to say it in a non-judgmental way. Like, I did a lot of active listening. I used reflections. Yep. All right. Well, hopefully some of this was useful to you all. So, a lot more comments. Great. Well, while you're looking at those, I also just want to ask the group kind of one more thing, and you don't have to put this in the chat, more just, but if you want to, you can. But for your own thinking, if there's something that you saw us talk about today, either a do or don't do, that you want to try and be mindful of, or try out for yourself, maybe pick something to try, whether it's just reflecting back, or asking permission to giving advice, or maybe emphasizing the autonomy, like once you do give advice, taking a step back and saying, so what do you think about that? Yeah, I'm curious, you know, people want to pick something that they want to try. So, okay, one person says she's going to ask permission before giving advice. Great. Okay. So before we go to questions, I want to just offer people some resources, things that they can utilize if they have more questions about either motivational interviewing or psychosis. So the first is the motivational interviewing book. It's now in its 4th edition. It's very good. It is really clinician focused, but I think anybody could get a lot out of it. It's called Motivational Interviewing, Helping People Change. I also wrote a book about motivational interviewing, which is more like adapted for informal caregivers, so like parents or teachers. And it's more about also a little bit more specific to adolescents and young adults. That book is called The School of Hard Talks, How to Have Real Conversations with Almost Grown Kids. I would also really recommend if you see patients who have psychosis and you feel like they could benefit from specialty care, you just need some ideas for what resources to offer them. You can contact the Massachusetts Psychosis Access and Triage Hub, or Empath, just Google that one. Or if you are looking for more training in psychosis, these webinars are an amazing resource. And even more webinars are put on by the Massachusetts Psychosis Network for early treatment. So those are also great resources for learning more about psychosis. And I think, Jenny, do we have anything else prepared? I think we can take a few questions.
Thank you so much. So folks can feel free to either unmute to ask their questions, or they can type in a question right into the chat.
So Emily, you use the word psychosis in the role play, and when is that okay to use it and when is it not?
You know what's so funny? Jenny and I practiced this morning with our colleagues, and that was the question we spent so much time on also. So I think great minds think alike. And I don't have like a hard and fast answer to this. I think it can be useful to give the education about why you're making certain treatment recommendations, right? Like if somebody really is, you know, like if I don't want to be callous, like I think if somebody really says, well, I'm not safe in my apartment, I'm like, well, let's get the police on board, right? Like this is a safety issue. But if I have a sense that this is more of a mental health issue, I want to be somewhat transparent about that, right? So I chose to use the word psychosis in the role play so that, you know, I wasn't sort of, I don't know, being overly dismissive of her safety concerns, I guess. But I also think that some people are really reactive to that, and you just never know. And I'm fine with also just doing what works and using the language that people themselves bring to the encounter. I don't know, Jenny, what do you think about that?
No, I agree. I mean, every person is different. It's really hard. I know I appreciated hearing a label from some of my experiences, but I also did push it for a really long time. And so I don't think there's a clear-cut answer. You kind of have to feel it out, I think, person to person, and kind of see what feels right.
I see a question in the chat about making professional recommendations assertive, and my language around that, and why I use that word. And so one thing is that my answer to that is that I think people can be sometimes a little bit too cautious in making recommendations, and especially when people are confused or they're in a lot of distress, that might be confusing to them. And I use the example of my own doctor who is very respectful of me. And I don't know if it's because I'm like also, you know, clinical faculty at the hospital, but she's like, yeah, I want to switch your medications. Like, here's the options. Which do you think? And I'm like, I don't know. Like, that's not my specialty, right? I'm going to do what she says. And I want her to be clear and to make a clear recommendation to me. I find that really, really helpful. And I think especially if people are in psychosis and their thinking might be a little bit foggy or confused, it helps to be really clear and assertive and say, I think you should do this, rather than presenting a huge menu or being wishy-washy. So I do think it's good to be assertive and at the same time, respectful that in again, 99 out of 100 times, it's the other person's choice whether they're going to follow that recommendation, but at least I've made it, right? So that's why I use that language, and I hope that's helpful. Another question is this one about, I like this question about what if the person has experienced psychosis for years? And in that case, I think I would spend a little bit more time on this question of like, what has helped you in the past, right? And kind of recognize that this is not like a brand new crisis for them. And they certainly do have some experience in managing these problems, and really lean into that and take their history pretty seriously, right? If they say, well, the hospital has been helpful or hasn't been helpful, I'm likely to take that pretty seriously because they're telling me, right? Or, you know, calling my sister has been helpful, calling my parents hasn't been helpful. Also just good information. So that's my short answer to that question.
I do have a question. I have a young lady who has a neurological issue that stems to the psychosis, and she also has dementia. What can I do to help her?
Oh, interesting. So, you know, dementia psychosis is really, really common. And it's not my area. I actually, when I was more on social media, I was like following a lot of dementia caregiving accounts because the ways that people have of managing dementia psychosis are very different than what we do with younger people who are in primary psychotic disorders. And I find that interesting, you know, but a lot of what I saw there is about sort of managing the distress and providing reassurance to people, that they, you know, that they're in a familiar setting and that you're going to help them with their concern. But you know, it's tricky because I know in a lot of nursing homes, like they prescribe a lot of antipsychotics, and it's just not my specialty. But yeah, I'm sorry, I can't be more helpful. So some more questions. A question about is psychosis on the rise? That's a really interesting question. I don't know the answer actually. And Michelle, maybe you have seen statistics that I don't, but the one factor that I think is of concern is actually the rising prevalence of cannabis and stimulant use actually in the community, because those are two sort of known catalysts in vulnerable individuals for psychotic disorders. So I don't know if the overall prevalence is increasing, but I'm concerned about it, given the increased rates of usage of those particular classes of substances. Okay, thanks, Michael. Any other questions I've missed?
Emily, what would you say to the woman with the nail?
Oh, great question. Well, I would probably just reflect. I'd be like, so you've got these headaches. Gosh, that's so frustrating with your sweaters. I would probably say, what do you think is making your sweaters get snagged? I'm curious about that. And then I might ask her if she, I might say something like, can I offer, sometimes just getting an outside perspective is helpful. Can I offer some thoughts? Then I might say, well, you do have a nail in your head, just like he said, but I would probably preface it with some more questions and some thoughtful reflection, and let her take her time maybe in the conversation.
There's one more question that I saw, which was, oh, sorry, someone's talking to me. Sorry about that. There was one more question in the chat about your thoughts on involuntary commitment for severe psychosis. Would you involve adult protective
Oh.
services?
It's very case by case, and it seems like I did see that question. I assumed it was from outside of Massachusetts, because we have very limited options for that here anyway. So I think my mind doesn't tend to go in that direction because, again, just legally, we don't have any kind of assisted outpatient treatment in our state, and so pretty much everything has to be voluntary outside of like people who are, awaiting like competency hearings in legal settings or, very brief, like 72-hour long hospital holds. I don't know. I honestly, it's something I want to learn more about because I understand that in other states, it's used and maybe some people have good outcomes from it, but it's a confusing issue for me because, again, my experience is so limited and specific to the context of my state where we have almost nothing that's really mandatory.
So a question about if a client is houseless, are there specific practices to move along with this client's goals, like Social Security claim, housing, primary care? Showing those things can help with understanding the client's direct goals. The client directs the goals.
Sometimes just the process of building trust can take a while. And helping somebody with the needs that they recognize, like even if it seems like unproductive, frankly, can help build that trust over time. So, for instance, going back to the nail video to say, wow, it sounds like you need some new sweaters. Right. Or if that's her, if I say, what would be helpful today? And she says, well, I really just need to figure out how to get new sweaters because all my sweaters are snagged and torn up. And she doesn't accept my recommendation about the nail. I might say, okay, well, let's work on that. And again, it's not an option in all settings, but I think it can be really useful for just kind of building that relationship over time. And I've had certain cases where that has been really successful because we've been patient. And built trust over time. And then the person was eventually willing to accept more of the treatment recommendations.
Thanks, Emily. And also Jessica's asking more specifically about talking with an unhoused client who believes voices they hear are being put there by the FBI and they're unwilling to accept a potential psychosis diagnosis.
Sad cases. I mean, I hate to see people living in such conditions and with poor quality of life. It seems really, really wrong. And again, if I lived in another state, maybe I would have another opinion about this. But from my vantage point, there's often, not that much we can do other than trying to meet the needs that the person themselves is expressing and build trust over time. And offer, the idea of respite, right? Or it's like maybe a treatment setting can be a respite from this difficult situation, even if we can't agree on exactly what that situation is. Maybe you can make an argument to the person that even if the FBI is on your case, the hospital is, less likely to be monitored than the street. I don't know.
Thank you so much. You've given us a lot to think about, and I think the style of seeing you act out the two scenarios along with the slide was very useful. We will be sharing a copy of these slides and the recording with everyone who registered. It'll also be available on the New England MHTTC website for folks who might not have made it today or registered yet. And I just want to really tremendously. Thank you, Emily and Jenny, for your time today, your thoughtfulness. Oh, there's a couple more questions that are coming in. You can decide if you want to try to address those before we stop. But I just wanted to make sure if folks are signing off that I had a chance to really express our appreciation.
You are welcome. And yeah, for more resources on working with family caregivers or guardians, I think the I'm not sick, I don't need help is like sort of a classic in the genre of talking to people who are psychotic from a caregiver perspective. And I get into this a little bit in my book too. Toward the end, I talk more about situations in which, not just sort of normal teenage problems or young adult problems, but specific problems of talking to people who have mental health concerns and using these strategies. Those are just kind of two ideas for things you can recommend. The other book is I'm Not Sick, I Don't Need Help. Great, thank you.
Have a good afternoon, everybody. Thank you.